Okay, so welcome to Rounds. February is Heart Month, so we decided to talk about EKGs. Can everybody see the slides okay? Any problems with that? We good? All right, so first, some housekeeping items. Train credits. It was brought to my attention that you guys aren't getting credits through train through the state. So I was able to speak with the office, and I guess what happened is that as of 12/31/21, so the end of last year, the train credits were automatic. So going forward for this year, I have to submit each class so that we get credits through train. So I will certainly do that. I've talked to Eric already, and we'll be able to do it for going backwards through January and of course tonight, and then going forward I'll just apply as the new rounds are coming up. So next EMS rounds will be March 15th, 1 month from tonight. We'll go with the Zoom platform again, 6 p.m. on Zoom, and it'll be about toxicologic emergencies or toxicology. So that's what we'll do going forward. Again, I kind of reiterate, if anybody has any specific topics you want to cover or anything that you want to learn about, please feel free to let me know. So if not, we'll go right into tonight. Again, this is about EKGs. This is one of the first EKGs. This is way back when they were first deciding that they could measure the electricity coming from the heart, and you can see it's pretty primitive, especially at what we're doing today. The objectives tonight, if you're looking to learn about vectors and Einthoven's triangle and voltage and stuff like that, I'm not going to talk about that. I'm not going to talk about how the P waves, the Q waves, whatever. We're not going to talk about EKGs specifically, how they're measured or how why the tracing looks like it does. But what I'm going to talk about is what happens when you actually see the EKG and what do you have to do about it. So this idea came to me about 2 years ago because we, as attendings in the ER, we see a lot of EKGs, and anybody who comes in with chest pain, dizziness, sometimes abdominal pain, they're doing EKGs on these people, and they're getting, they're putting them in front of us so that we can, take a quick look. And, the question is, do I have to get up and do something, or is this something that can wait, right? So this is the EKG class where, you take one quick look at it and you decide if you have to do something or not. So that's what we're going to be talking about tonight. And again, we'll talk about, intervals and stuff like that as things come up, but it's not a EKG 101, let's put it that way. So, and I'm going to do it by way of, just presenting cases. This lecture is certainly does much better when you do it live, because I can kind of, ask people questions in the room and kind of point to the EKGs and ask things. But, unfortunately, we're on this platform. So we'll do it this way. And, I'll give you time to look at the EKG. I won't try to ask for questions or whatever, but it's, can get messy with a lot of people, but we'll see what we can do. We'll get by. So let's just start with the cases, and I'm going to have, I think there's 10 after all, and all of these are true cases, are real cases, other than one, and I'll tell you about that one. But these are all people that I've seen, and you've probably seen, in your practice, but these are real cases. So the first case is a 42-year-old man. He's playing basketball with some friends 2 days ago. And since that day, since he played basketball, he's been having intermittent chest pains. So of course, chest pain, you get an EKG and you get something that looks like this. So again, I'm going to give you just a few minutes to kind of look at it. And I know I can't, query the room, so to speak, but just take a quick look at that. And if there's any. And this is a normal EKG. All right, so let's go back and just take a look. This is a normal EKG, and again, I'm not going to go over all the specifics of the waves. I'm going to assume like you guys know that, But you have to remember that you're going to see a lot of normals in your practice, right? You're going to see a lot of normal EKGs. Doesn't rule out that this guy's having some kind of event or acute coronary syndrome, et cetera. Just looking at the chat real quick. So, but again, you're going to see a lot of normals, and you have to know what normal is, right? I mean, how can you know what is abnormal if you don't understand what normal is? So again, sitting in the ER when people are putting EKGs in front of us, we're going to see a lot of normal EKGs, and that's okay. But again, you have to know what normal is before you start seeing what's abnormal. So let's move on. So case 2 is a 55-year-old man having chest pain, pressure. It's been off and on for the past 2 days. He's a twin, and his twin brother, who's actually with him in the ER. Actually, this is an ER case, but his twin brother's with him. He's had an MI that required PCI and stents. So the patient himself is diaphoretic with the pain. So this is his ECG. So again, take a quick look. And hopefully what you can see here is that there's elevation here in V1 and V2. So there's ST elevation. So this is an ST elevation MI, V1, V2. Let's look at this and see that we know that the 12 lead kind of maps out the heart and maps out the coronary artery distribution and anatomy. And we know, looking at the table way at the bottom of this page, that V1 and V2, like in this guy's case, he was having a septal MI. We know that 2, 3, and AVF represent the inferior part of the heart. 1 AVL and V5, V6 are the lateral part of the heart, and then V4, V3, V4 the anterior part of the heart. So again, the heart is pretty well mapped out by the ECG, and you can tell where the problem is happening just by looking at it. So for just a little practice on that, you can see this ECG. You can see that there is, or hopefully you can see, ST elevation in 2, 3, and AVF, which suggests that this is an inferior MI. So again, 2, 3, and AVF is inferior. This one is a little trickier to see, and this is what this is the sort of the hidden lead that nobody really thinks about, is the AVR lead. And if you look in AVR, there is elevation in AVR. And if you see elevation in AVR alone, that is indicative of a left main disease until proven otherwise. So sort of the moral of the story here is don't forget about lead AVR. So what are the causes of ST segment elevation? Well, certainly myocardial injury, and that's what this guy had. But there are some other mimics, right? There are other things that can cause the ST segment to elevate or maybe look like it's elevated. Acute pericarditis, a bundle branch block, early repolarization, hyperkalemia, and we'll talk about each of these as causes of ST segment elevation. So let's take a look at acute pericarditis. What is pericarditis? Well, the normal pericardium you see on the left, there's a sort of a sac around the heart that's filled with fluid, and that's the pericardial sac. When that becomes inflamed or infected or just irritated, you may get some pericardial effusion, or certainly what we call pericarditis. So inflammation of that pericardial sac, typically caused by like a viral illness. So if somebody has a viral syndrome, they may get this, a few days after a viral syndrome. So what happens is you have all these, you have all these positive vectors coming from everywhere on the heart. It's showing an injury pattern everywhere on the heart because it's the sac around the heart. So what you'll see on EKG then is ST elevation everywhere. So you'll see it in 1, 2, 3, the AVR, AVL, AVF. You can see it laterally as well. So there's ST elevation everywhere because the heart is surrounded and it's sending off these vectors everywhere. So that's what acute pericarditis would look like. Left bundle branch block is another thing that sometimes gives us some problems because you say, well, these big, ST things here, is that a bundle or is that ST elevation? So again, that can be a mimic for ST elevation. So let's look at, again, I wasn't, we're not doing this specifically, but in this case, we're going to talk about bundles. So let's look at the electrical conduction system. If you remember, the SA node, the AV node, the bundle of His, et cetera. So what happens is the impulse is generated by the pacemaker in the atria or the AV node, and then it's normally conducted down through the conduction system, down the bundle branches, and it innervates the myocardium in a very organized fashion. So that's what happens normally. What happens when you have a blocked bundle branch is that the impulse can't proceed through that normal pathway. So instead, it has to go cell by cell, which is very slow. So it slows down the transmission, which widens the QRS, and we'll see that on the EKG. And then that accounts for that, again, that wide bizarre complex that you see on the EKG. So let's kind of look at right bundle. So first, again, as the conduction comes down through the bundle of His and then it breaks right and left, if you have a block in the right bundle, the QRS is prolonged. Again, it takes a long time for it to go cell by cell. So the QRS gets prolonged. You get a slurred S wave in leads 1 and V6, and you get the RS R prime pattern in lead V1 with R prime taller than R. And what does that look like? Well, that looks like this. So again, you get that slurred S wave in 1 and V6, and then you get what we call the RS R prime in V1, or the rabbit ears, right? We can all recognize the rabbit ears when we see it on an EKG. So if you see it here, you see again up in V1, the slurring of the S wave in 1 and V6. I can't really say that I see that so much, but I certainly see the rabbit ears up in V1. So if you see the rabbit ears in V1, that's a right bundle branch block, and that's what that looks like. Left bundle now, if you block the left side, the example they give here is like a rock thrown up in the air. It's either all up or all down. And you can see in V1, it's all down. In 1 and V6, it's all up. So the waves look something like this. So again, the QRS is prolonged because it goes cell to cell. It takes a long time to get through. You get these broad monomorphic R waves in 1 and V6 with no Q wave. So again, that's all up in 1 and V6. And then the same S waves in V1, so it's all down. So all up in 1 and V6 and all down in V1. And then it looks something like this. So this is a left bundle branch block. And you can see, like I said, you can see how this is sort of a mimic for ST elevation, because if you look in these areas here, you say, well, is this a left bundle or is this ST elevation? This is, again, this is another left bundle branch EKG. This is an EKG taken in the ER. And what are the causes of left bundle branch block? Well, these are the ones that are, the left bundle is maybe a little bit more serious, certainly, than the right bundle. Potential causes: hypertension, coronary artery disease, right? If you identify a left bundle branch block that is brand new in somebody, in other words, for whatever reason, they had an EKG yesterday and it wasn't there, and today they have a left bundle, that's as significant as finding an ST elevation MI, and they should go immediately to the cath lab. So a left bundle can be caused by coronary artery disease, dilated cardiomyopathy if the heart is just big, dilated for whatever reason, rheumatic heart disease, again, any signs of heart disease, infiltrative diseases of the heart, and benign or idiopathic causes. Most of the causes, though, the vast majority, are due to hypertension or coronary artery disease, or both. So again, a left bundle is a little more indicative of heart disease, certainly, than a right bundle, and maybe a little more concerning, certainly, especially if you identify it as a new finding. Okay, let's talk about early repolarization. What is early repolarization? That just means that the ventricles are repolarizing earlier than usual. So if you remember, again, going back to the EKG basics, the QT interval is where the ventricle is repolarizing, and you can see what happens is it starts to repolarize early. So this what we call the J point is elevated, right? So instead of coming all the way down to baseline, the J point is elevated and it repolarizes early. And you can see that happens all throughout, right? So you have this kind of, it looks like ST elevation, but what's happening again is the heart is repolarizing early. This used to be thought of as pretty insignificant, and most of the times it is. Let's put it that way. So you may see this in a young, healthy, most times athletic type person who has a well-functioning heart, maybe a thick heart, and it may repolarize early, and that's okay certainly in a young, healthy person. If you see this in older people, again, we used to think of this as not specific, but they're finding that in older people this is a problem, or could lead to a problem, could lead to a dysrhythmia. So again, it depends on your age, it depends on the patient's history. Are there other signs and symptoms of acute coronary syndrome? Are there other things you're concerned about? But certainly this could look like ST elevation. So this is early repolarization. Again, this is another example of early repolarization. You see how the J point is elevated, and it kind of repolarizes early, and it takes off, and it kind of looks like the ST is elevated. Hyperkalemia. If anybody knows me, you know that I seem to talk about hyperkalemia a lot, or at least I feel like I do. Hyperkalemia, you get these big, tall, peaked T waves as the potassium starts to go up in the body. If the potassium is greater than 6 or 7 or so, you get these peak T waves, and you get the T waves that are actually bigger than the QRS. You can see how the T waves are taller here. And that can kind of make you think, well, again, is this ST elevation, or is this just a big T wave? So hyperkalemia can be one of these mimics of ST elevation. There is a way that this is, as you can tell probably from the slide, this is an old this was in an old book, but what they suggested is that if the ST segment is convex down, so kind of you see convex down on top, that's a frowny, right? So that's a bad thing. If it's concave up, that's a smiley, and that's a good thing. I don't know how much science is involved here, but certainly it could give you some hint. If you look at these ST elevations here, if you look particularly like here, this ST elevation, well, that looks like a frown, right? So that's frown, and that's down, so that's a bad thing. If you look at these ST elevations, again, this looks like either pericarditis or early repolarization or something. You see that it's convex up, and then you have a smiling. Again, I don't know that I put too much science here, but it could be hints to whether this is ST elevation in a bad way or not. What is helpful, though, is especially in an MI, is that you'll see reciprocal changes when you see myocardial injury. So what happens is, if we go back to this EKG where you have ST elevation in 2, 3, and AVF, right? So this is an inferior MI. In the reciprocal leads or the anterior leads, you'll see ST depression. So if you see elevation in 2, 3, and AVF, and you see depression in 1 and AVL, then this is a true myocardial injury. This is a true STEMI, and there's nothing else that will do that. So again, look for reciprocal changes. These are hints to, true ST elevation. You're going to also see PR depression in pericarditis. Again, when you look at pericarditis, that can be kind of deceiving, because you say, well, this clearly looks like elevation here. Maybe not so much here, out here, right? So sometimes it's hard to tell. But if you look in pericarditis, if you look at the PR interval, the PR interval is depressed. So not only will you see ST elevation, but you'll see depression of the PR interval. Again, this can be helpful to discern pericarditis from ST elevation MI. Now, again, I don't think we'd fault anybody in looking at this EKG and saying, it looks like ST elevation, I'm going to the cath lab, or I'm going to a hospital with a cath lab. Let them make the decision. So, but again, PR depression is helpful in pericarditis. So let's talk about out-of-hospital care with MIs, with STEMIs. Most patients don't seek medical treatment for 2 hours or more after symptom onset. And what's the problem with that? Well, they're at relative risk of sudden death in the first hour, right? So they've already waited too long. So that's the importance of EKGs in pre-hospital care, certainly. And the survival rate for U.S. patients hospitalized with an MI is pretty good. So obviously, to get to a hospital is a good thing, especially in the United States. if you do have a patient that is considered high risk, and so that's signs of cardiogenic shock or pulmonary congestion or edema. If the heart rate's greater than 100, the systolic blood pressure is less than 100, ideally these patients should go to a facility capable of PCI revascularization. Okay, so now this stuff is getting kind of old now, but this is the AHA guidelines. You can see from back in 2007. These are for patients with chest pain that, whether unstable angina or non-ST elevation MI. It's reasonable that all pre-hospital EMS providers perform and evaluate 12-lead EKGs in the field for patients with chest pain. I think that makes sense, right? And I'm sure, the protocol says anybody with chest pain gets a 12-lead ECG. And certainly anybody that you suspect ST elevation MI, whether their story is good or whatever, they look like they're having an MI, certainly a 12-lead is, should be routine on all these patients. And of course, in the hospital too, for those of you who are in the hospital, or if you, work in the hospital, it's recommended that somebody who presents to the ER, presents to the hospital with chest pain or chest discomfort should get an EKG within 10 minutes. And again, these are the EKGs that we're seeing all day long for people who have chest pain or dizziness or abdominal pain, because you don't want to miss it. You don't want to, miss the true ST elevation MI. So EMS 12 leads, there were some studies, again, they're rather old, but studies show that they increase scene time by 1.84 minutes or 1.19 minutes, depending on which study you look at. So really not a lot of increased scene time, certainly to do a 12-lead EKG. So that's not a good excuse. And the other thing, this was a study, done in Boston, and they looked at, can paramedics actually read 12 leads accurately? And people who have seen this lecture of mine before, I know that they love this slide to show that paramedics are actually, or actually ranked better than ER doctors and just slightly less than cardiologists. So the important thing, take home message here is that, yeah, you not only can you do it, but you can read it and you're accurate in doing so. So again, a good reason to do it. It adds, so in summary here, I guess it adds only 1 to 2 minutes of in-field time. They're high quality, certainly they're the same quality that we have in the ER. Interpretations are comparable to in-hospital, I showed you that. It increases the early diagnosis of STEMI or ST elevation MI, and certainly makes EMS a part of the emergency cardiac team. That's all fine and good, but if you do a 12 lead, we have to see it, right? I mean, if you do a 12 lead in the ambulance, please, you have to include it as part of your report. Otherwise, it means absolutely nothing. So please remember to print out your 12 leads and make them part of your report. All right, so that was, I think we covered STEMI pretty well. Let's go on to case 3. This is a 74-year-old male. His complaint is general weakness. I know we've all seen this guy, right? He hasn't been feeling well all day. He's had a poor appetite. He had some vomiting, had some diarrhea. His wife found him on the bathroom floor. And she tells you, well, yeah, he's been treated for CHF in the past and he has some kidney problems, right? So this is his 12 lead. Again, this is attached to the back of the PCR. This is his 12 lead. And you get a 12 lead in the ER that looks like this. I'll give you a minute to kind of digest that one. So that's his 12 lead. I can show you that he was given an intervention between this, and you can see the difference in the EKG there. And this is hyperkalemia. And like I said, I seem to talk a lot about hyperkalemia because I think it's one of those, really cool things that you can recognize and do something about. Hyperkalemia is a high potassium, serum potassium. It's defined as a measured serum potassium more than 5.5. And what happens is that the manifestations usually result from derangement in membrane polarization. And we'll take a look at that in a second. But the cardiac manifestations are the most serious, certainly. So the cardiac membrane is affected, and that is serious. And you do see the ECG changes. As I showed you, that first one, that the tall peaked T waves, the short QT interval, and then a prolonged PR happens when the potassium starts to get about 6.5 to 7.5. Once you get over 8 or so, the QRS starts to widen. It flattens the P wave. And then as the potassium gets up in real dangerous levels, 10 to 12, the QRS may actually degrade to what we call a sine wave. So this guy that we're talking about had, I think if I remember right, he had a potassium of about 9. This is the same hyperkalemia EKG I showed you with as an ST elevation mimic. You can see the tall peak T waves. Again, this is when the potassium is about 6.5 to 7.5. As it gets bigger, as it gets higher, potassium gets higher, you can see that the QRS widens, the P wave kind of drops out, and eventually you get to a sine wave. This is a guy that I actually saw just a week ago in the ER. So you can see on the bottom here, you can see this tracing here. This is almost like a sine wave because his potassium was elevated. So again, this is something that you want to recognize because you can do something about it right away. And what do we do? Well, the first thing we want to do is that we want to stabilize the membrane. As I told you, the cardiac membrane is at risk here. So you want to stabilize the membrane. You want to shift potassium from the extracellular fluid back into the cell where it belongs. And then you lower the measurement of potassium. And then eventually you want to just remove potassium from the body. So we have ways of doing that. So what can you do? Well, this is the membrane. And not to get too involved with this, but the calcium, sodium, and potassium are exchanging with each other through these different channels, and that's what keeps the membrane stable. So what can we do? And certainly you can do something in the field. First thing, again, is you want to stabilize the membrane, and you do that with calcium. So I just showed you the way that calcium and potassium and sodium are interchanging through those channels. You want to give calcium, either calcium chloride or calcium gluconate. Either one, you want to give calcium to stabilize the membrane. That's the first thing to prevent any sudden cardiac event. You want to redistribute the potassium. I told you, you want to move it from the extracellular fluid into the intercellular fluid. And to do that, you can give sodium bicarb. You can see there 1 to 2 amps IV over 2 minutes. When I showed you that initial ECG of the hyperkalemia and said that an intervention was done to do the next one, he was given sodium bicarb. So you can see just by giving sodium bicarb, the QRS went from really wide to more narrow. So sodium bicarb is a treatment. And then albuterol gets rid of redistributes potassium. So albuterol is a way to lower potassium level as well. And then elimination, we just want to get it out of the body. And I know that Lasix is in or out of the protocol, depending on the month, but certainly Lasix helps the person get rid of potassium by excreting it in the urine. So these are things we can start to do in the field. And this is in your protocol. If you look on, dialysis emergencies and renal failure, again, if you remember, this guy had a history of renal failure, and certainly people who have renal failure or certainly are on dialysis can't get rid of potassium. So the potassium builds up, and that's what causes the hyperkalemia. You can see here, it mentions calcium chloride or calcium gluconate, sodium bicarb, as we talked about. So again, these are the things that you can do in the field. Certainly, if you have a patient who has cardiac arrest, who is a dialysis patient, arrests either during dialysis or that they're a dialysis patient, certainly bicarb and calcium should be on your, sort of the top of the list to start giving for arrest. Yep. And then again, in the ER, the thing that works best for us, certainly, and I know that you can't give, is insulin. So we're going to start giving insulin in the ER to redistribute potassium from extracellular to intracellular. And we can give things like, cation exchange resins for the person to start actually having lots of bowel movements to get rid of the potassium as well. So again, just ways to get rid of potassium. So that's hyperkalemia. So you don't want to miss that, because like I said, this is something that if you're probably going to see in your career, and certainly you can do a lot about, and certainly can protect people and do a lot to help them. All right, moving on. Case 4 is a 45-year-old woman with a complaint of palpitations. She's been having these attacks for several months. The attacks make her feel anxious and like her heart is beating out of her chest, and she thinks she's having anxiety attacks. And you get a 12 lead and you see this. All right, so just give you a few seconds to look at that. And you should recognize that as a narrow complex tachycardia and probably SVT. How do we count the rate of an EKG? Well, we look at the EKG. Remember that five of the big boxes, right? These bigger boxes, the darker lines, 5 of the big boxes is 1 second. So if you start on 1 peak and you count to here, this would be a rate of 300, 150, 100, 75, 60. So this is somewhere in between. So this is probably 60 something, right? So again, this is a quick way to calculate rate when you're calculating the rate of an EKG. And if you look at this one, if you look at the rate here, if you pick a QRS that's lining up here, you can see that this is 300, 150. So this is probably somewhere in the 2 something range, right? So this is a fast, narrow complex tachycardia. And again, probably SVT. So what do we do for that? Well, this is, we've made it a lot easier with narrow complex tachycardia versus wide complex tachycardia. You don't have to remember, SVT, VTAC, whatever. You just know that it's narrow or you know that it's wide, right? So in this case, the narrow complex tachycardia, and certainly you can try vagal maneuvers and things like that. You can move on to adenosine if you think, if it doesn't stop or if you don't need it. Certainly any of these rhythms that are unstable, these tachycardic rhythms that are unstable may need cardioversion. Right. So if this patient presents, with a blood pressure that's quite low or they're otherwise unstable, then this is somebody who needs cardioversion, and you can see that in the protocol as well. So this is SVT, and I think the thing to remember about this is people who present or call you because they're having anxiety attacks. It's very easy to say, yeah, it's probably an anxiety attack, probably a panic attack, but we have to rule out the other stuff first, right? The anxiety should be a diagnosis of exclusion. Make sure they're not having an underlying rhythm disorder or something that's causing, these attacks. And again, I've seen it plenty of times in the ER where they actually have a rhythm disturbance that's causing their symptoms. All right, so you don't want to miss SVT. You don't want to miss the narrow complex tachycardia, especially, again, unstable. You want to cardiovert. Stable, you have some medication options. All right, case 5. This is an 85-year-old man with increased swelling in his legs bilaterally. Sometimes his legs get so edematous that they weep fluid. He was on Lasix, but his doctor discontinued it rather recently. So this guy has some cardiac issues, right? He has, sounds like he's having CHF. He comes with an EKG that looks like this. And again, I'll give you just a few minutes. I think I have his. All right, so this is wide complex tachycardia as opposed to narrow complex tachycardia. So again, the QRS is greater than 0.12 seconds or greater than 3 boxes, right? So same thing with either of these tachycardic rhythms. If they're unstable, if the blood pressure is low or they're otherwise unstable, then cardioversion is certainly your first option or your best option. After that, there are some medical options. Amiodarone in this case, or lidocaine still is in the protocol. And then if you can't tell, or you can't tell if it's wide or narrow, and it's fast, you can always give the dose of adenosine and just see what happens with the rhythm, right? So this is a wide complex tachycardia. You can see how the QRS is wider and then 3 boxes. You can also see, if you look closely, you can see that little notch on the top, almost like a rabbit ear kind of notch. So you know that there's a that it's some aberrant conduction going on. So again, this is, I believe, this is his actual EKG. This is the 85-year-old guy with the weepy legs. This was his EKG, and you can see that it's VTAC, and it's not quite as fast as SVT. SVT can get up in the 200 and 220, 250 range. VTAC is usually a bit slower than that. And this guy, when we slowed him down, actually, you can see that he had an underlying like AFib or something going on. So again, this is wide complex tachycardia or VTAC, and you don't want to miss. So again, we've taken all the, the diagnosis out of it and just call it narrow complex or wide complex tachycardias. But again, you certainly want to be able to intervene when you can. All right, case 6. This is an 80-year-old woman with episodes of dizziness. She was standing in the kitchen near the sink and suddenly found herself on the floor. Doesn't really know how that happened. She denies any injury from falling. She just kind of fell and doesn't really know what happened. So this is, probably syncope until proven otherwise, right? So you get a 12-lead ECG and it looks like this. I'm going to give you a minute on this one to take a quick look. Do what you do, look at the P's, look at the QRS's, and you should notice certainly that the rate is pretty slow, right? It's probably around 50 or so. And there's really no relation between the QRS and the P waves, right? So this is, or at least I hope you see that it's complete heart block. And this, again, falls under the bradycardia protocol, which is more general, but this is complete heart block. Again, you see that there's no association between P waves and QRS. And this is complete or third degree heart block. Can you give atropine for this? Well, you can, but it's not going to do anything, right? So the blocks that are below the AV node, like the type 2 second degree block, or certainly the third degree block, like this is complete heart block, the atropine is not going to have any effect on the rate. So atropine is probably not going to do anything. The only thing that you can do in this case is pacing. The important thing to know about this ECG is, what's her blood pressure, right? So if you come in with this lady who had just had syncope at home, she has this ECG with complete heart block and her blood pressure is 120/80. Well, then we're not too as concerned as, as if she had a blood pressure of 50, right? So, if you can start pacing, or certainly we can plan for, transvenous pacer with a eventual permanent pacemaker. And that's exactly what happened to this lady. She had a permanent pacemaker put in. So again, you don't want to miss complete heart block. You don't want to miss, things that, again, are going to need prompt intervention and treatment. Okay, moving on. Case 7, 55-year-old man having chest pain pressure off and on for the past 2 days. He's a twin. His twin brother has had an MI requiring PCI and stents. He's diaphoretic. Sound familiar? I hope it sounds familiar because we've already talked about this guy. This is the same guy that we talked about with ST elevation MI, and certainly he was having an ST elevation MI. It was septal. It was V1 and V2 where he had ST elevation. He eventually went to the cath lab. But why am I talking about him again? Well, because this was his first EKG. And this was a guy that was in the ER for a while. And he was signed out to me. He was seen by a colleague of mine prior to me coming in. And he was there for a while and he was having chest pain and he was diaphoretic. And his twin brother, this was pre-COVID, so we had visitors. His twin brother was sitting right next to him saying, this exact same thing happened to me and I had to have stents. I know that he's having a heart attack. The doctor who, signed out to me, who saw him, knew that he was having a heart attack, but just did not see it on the EKG. And he sent this EKG to the interventional cardiologist saying, I know this guy is having a heart attack, but it's just not shown on the EKG. And the interventional cardiologist agreed and said, no, it's really not. But then he started to complain of chest pain again, and we got another EKG. And guess what? That's when the ST elevation showed. So the importance of getting a second EKG or repeat EKGs here is really the take-home message. Don't rely on one EKG, especially if patient's symptoms are changing or, you have some time. Repeat it in 5 minutes, repeat it in 10 minutes, and you may see a completely different picture. So again, I was called to his bedside because he was complaining of chest pain, more chest pain, right? So we got that EKG, showed the ST elevation MI, but then as I was talking to him, he did this and he did this, and then he did this. So this was certainly was having a true event. He was defibrillated right away and then eventually, stabilized enough to get to the cath lab. So this is this was again, everybody knew he was having an MI, including his twin brother. But without that EKG, being definitive, he's not ready to go to the cath lab, but he did go to the cath lab and did well. The take-home point again is the repeat EKG. The EKG you don't want to miss in this case is a repeat. Again, you look at an EKG is 12 seconds, right? At 12 seconds in time. And if you don't catch something in 12 seconds, well, it behooves you to do another one. So do another one in 5 minutes, do another one in 10 minutes, certainly do another one if the patient is complaining of new symptoms or different symptoms or something like that. But the EKG here you don't want to miss is a repeat. Okay, case number 8. This is a 57-year-old woman found unresponsive by family at home. There were a lot of empty pill bottles on her nightstand. She was being treated for depression, some other mental health issues. She's had a previous suicide attempt in the past. So again, remember that on EKG, you may see some, concerning things based on medications. Again, I'll give you just a few minutes to look at this one. And hopefully, or maybe you can see that the QT looks long here, right? So if you look quickly at this EKG, you can say something is wrong, and it looks like the QT is way too long. And that's exactly what's happening. This is a long QT syndrome. This is a long QT on ECG. This could be either congenital or acquired. Congenital, some people are born with a long QT syndrome, and they can certainly tell you about it or be on medications for it. But in this case, it's acquired because it's a disorder of cardiac repolarization due to either drugs or hypokalemia or hypomagnesemia, so low potassium, low magnesium, or again, certain drugs or medications. And certainly this lady was on some medications that caused a long QT. So what happens when you have a long QT? Well, what is the QT? What is that portion of the EKG? What does that represent? Well, the QT, again, that QT is the repolarization phase, right? That's it represents all of systole, and the ventricles are repolarizing. And the problem is this little red area here, you have what we call an absolute refractory period where nothing else can happen. But then you have that relative refractory period where, if another stimulus comes there, then you end up with trouble. And people, you may know that, people with prolonged QT syndromes are at risk for something called a polymorphic ventricular tachycardia, or better known as torsade de pointe, right? So this is French for twisting of the points. It looks like it's the EKG is actually twisting, and this is sort of the bad end result of a long QT syndrome. If you have another stimulus during that relative refractory period, then you go into this form of ventricular tachycardia or torsade de pointe. The treatment for this is magnesium, 2 grams of magnesium IV, irrespective of the magnesium level, followed by a magnesium drip. So again, this is that's the treatment for a little bit different treatment here for this type of VTAC, certainly, but magnesium is the treatment for torsade. You can also overdrive pace. You can try to capture faster than the VTAC is going, and you can overdrive pace. But these are the treatments for the torsade. And again, this is from long QT syndrome. What's the QTc interval? If you have an EKG machine and that it spits out a computer reading on top, it'll give you the PR interval, the QS or whatever, but it's going to give you the QT, and then it's going to give you the QTc, which stands for QT corrected. Why is it corrected? Well, you can imagine that if the heart rate as the heart rate slows down, the QT interval is going to get longer and longer. If the heart rate speeds up, the QT interval is going to shorten because it's based on what's happening in the rest of the cycle. So the QT corrected just shows you what the true QT interval is. And now you can see that there's a formula there. And again, if nowadays we have computers, thankfully, that calculate the QTc. So really you want to look at the QTc, the QT corrected, meaning that the QT interval has been corrected for rate. And that will let you know if it's anything greater than 0.419 seconds is a long QT interval. So again, this helps you to determine a long QT interval on EKG. So you don't want to miss long QT, especially because we're using medications. Zofran is the big one, right? Everybody's getting Zofran for nausea and whatever. But Zofran is a medication that can prolong the QT interval. So if you have somebody who, like in this lady's case, she's overdosed, maybe she's vomiting because she's overdosed on a bunch of things. You certainly don't want to give her something like Zofran that's going to prolong her QT even longer. Et cetera. So you got to kind of know what medications are and what medications are doing. So that's the long QT interval. Case number 9. This is a 40-year-old man who passed out in Stop and Shop. By the time you guys get there, EMS gets there, he's awake and alert. He has no other complaints. He has no significant medical history. He just kind of passed out, and now he's awake and alert and fine. And this is his EKG. And I can tell you that the other cases are all actual cases. This is a case I have never seen, but this is one that you really want to pick up if you do see it. And this is called the Brugada Syndrome. And what the Brugada Syndrome is, it's an autosomal dominant inherited disorder affecting the cardiac sodium channel, so that these people are at risk for dysrhythmias because of a defective sodium channel. And what you see in V2 and V3 is you see this funny looking QRS or ST morphology. You just see something that doesn't quite look right. And again, that's what the whole theme is here. We're just looking at an EKG quickly. Something doesn't look right. So something you can see here, V1, V2, something doesn't look right. And this is the Brugada syndrome. So what is that? So the patients who have Brugada syndrome are at risk for sudden cardiac death from ventricular fibrillation. Again, it's a faulty sodium channel. And patients may have episodes where they have episodes of syncope or they pass out prior to any ventricular problem. So, in this guy's case, he just passed out in the store. This is not an old diagnosis. It's relatively new. You can see described in 1992. More common in males than females, and for some reason more common in people of Asian descent. Again, it's an autosomal dominant inherited disorder. So, for whatever reason, it's in the common in Asian descent males more than females. And it was, they looked at this back in, again, the early 90s, 80s, 90s, and they called it the sudden unexplained nocturnal death syndrome. Because what was happening is that these Asian males were dying in their sleep, or at least not waking up. So they thought something was happening in their sleep to cause them to die. And they actually thought that it was from nightmares. They actually thought that these young men, otherwise young, healthy men, were having nightmares, and somehow that stopped their heart in their sleep. And just again, I like history. I like all kinds of history, but anyway, nightmares, I thought about the word nightmare and where that actually comes from. And it actually comes from this little creature right here, was called a mare in Old English, and not a mare like a horse mare that you see back here, but this thing is a mare. And they thought these things came in the middle of the night and caused nightmares. So if you ever wonder where that word came from, that's where it comes from. But anyway, So they thought that these young Asian men were having nightmares and dying in their sleep from that, and was stopping their heart or whatever. But what they found again was that it's a problem with the sodium channel that leads to ventricular fibrillation and then death. So again, if you see a young man or a young woman, Asian descent or not, if they've passed out and you see that weird looking EKG, then that's a Brugada syndrome, and you can certainly save somebody's life from identifying it, because what they need is an implantable cardioverter defibrillator. So they need a defibrillator because of the risk of ventricular fibrillation. So that's Brugada syndrome. So again, these are the EKGs you don't want to miss. I guess there were 9 of them, not 10. So normal, STEMI, hyperkalemia, SVT, VTAC, complete heart block, repeat EKG, long QT, Brugada syndrome. So I guess I kind of put you through the ringer a bit, and we've hopefully come up with something that we can work with, right? So again, this was not meant to be, EKG 101, how do I read an EKG? But certainly, okay, here's my EKG. What is it? Can I identify what I see, just by quickly looking at the 12 lead? Is it stable or unstable? Is this somebody that I, have some time to think about, or is this something I need to, really do something about? And again, I liken it to, seeing EKGs in the ER, is this something that I have to get up out of my chair, or is this something that can wait, right? So do I need to rush to the patient's side or not? And certainly, do I have to do anything about what I'm seeing, right? Is there some intervention that I can do right away based on what I'm seeing on the EKG? So if you have any questions, again, just to review, and I can open up chat after this, or you can unmute yourself. But certainly a normal EKG, you're going to see a lot of normals, right? You have to know what normal looks like before you know what abnormal is. ST elevation, and there are lots of mimics. I don't think anybody's ever going to fault you for, misdiagnosing an ST elevation MI if you see pericarditis or left bundle or something like that. But certainly, you do want to recognize ST elevation, because they need to go to a PCI capable hospital. Hyperkalemia, again, you're going to see it, especially with people with renal failure. This is when there's a chance for intervention here. SVT, or the narrow complex tachycardias, or VT, or the wide complex tachycardias, again, differentiating between those and treating those. Complete heart block. You want to identify that, because these are people that may go on to need pacemaking, either by pacers by you, or certainly definitive care. The repeat EKG, I hope that I emphasized enough that one EKG may not be enough, or lots of times it's not enough. So to repeat one in 5 minutes, repeat one in 10 minutes, or to repeat one if symptoms change, is certainly a great idea. The long QT, you want to recognize that, because if you give medications or use medications that further prolong the QT interval, you can, put somebody into torsades, which is obviously not a good outcome. And then Brugada, just to be aware of the Brugada syndrome. Again, I have not seen it, but certainly if you do see it, you have a great chance to save someone's life. So I'm going to open up the chat box here if I can, and then if anybody has any questions, either on chat, or if you want to unmute, you can do that as well.
I just had one question about bundle branch blocks. If you don't have an old EKG to compare to, like you can't tell if it's new or old, I guess, what is your threshold to send that person to the cath lab or not?
Well, in specific, it's a left bundle, right? So if you have a left bundle branch block, and you have the right clinical scenario, right? You have somebody who's having chest pain, or they're diaphoretic, or they, whatever the case may be. If you have the right clinical scenario and you have a left bundle branch block and you can't identify if it's new or not, then I would say yes. I would treat that as a new left bundle until proven otherwise. If you're picking up an 85-year-old man who, fell and maybe broke his hip, and, you get an EKG for, just other reasons, then I would say not so much. But certainly if you have the right clinical scenario, then yes, I would treat it as ischemic.
Okay. And then I also just had a question about rate related bundle branch blocks. And if you are, I guess, is there any risk of slowing it down to see if it's rate related or not? Do you have any risk if that person actually is having some type of cardiac event?
Well, with any cardiac event, you don't want their heart rate going fast anyway, right? So I mean, that's more strain on the heart, more oxygen consumption, et cetera. So I think if it's a fast rhythm, no matter what it is, there's no harm in slowing it down if it's ischemic, and certainly that's a desired outcome, is to slow down a fast rhythm if they are ischemic.
Sure. Thank you.
Sure. Someone asked in chat, is there a range for Zofran causing prolonged QT dosage and timing wise? I don't think there's any range for dosing it. Zofran Zofran as a drug, one of the side effects is QT prolongation. So I would try to avoid Zofran in someone who's, has QT prolongation, if they tell you, oh, I have a congenital QT, prolonged syndrome, if they have a prolonged QT from drug overdose or other medications, or low potassium or low magnesium or something like that, I would avoid Zofran altogether. Question in chat: what do you usually utilize for a patient with active vomiting from overdose? So again, if you're worried about a QT prolongation, you don't want to use Zofran. Unfortunately, that doesn't leave you with a lot of options pre-hospitally, I guess. I mean, technically, Benadryl is a antiemetic. I'm not sure that would be of much help to you, but unfortunately, there's not a lot of options in the pre-hospital world other than Zofran. So I guess if you had an overdose and you did an ECG and they had a normal QT interval, then I would feel, better about using Zofran, certainly. So again, next month, March 15th, we'll do toxicology. Probably hear some of these things again about QT intervals and stuff like that, but that'll be the plan for March. Again, if anybody has any ideas of what you want for rounds, or what you'd like to hear about, and I have heard some suggestions from last time, but certainly let me know, and we'll do the best we can. I know we still owe you a legal lecture. We had a lawyer set up for I guess it was last year, to do a documentation type rounds, and unfortunately that got canceled. So we'll see what we can do to get that back on the books.
Dr. Jardine, I do have a non-clinical question. It's Katie.
Oh, hi, Katie.
Hi, I have a few guests here, and their Zoom names are just their first name. And I just was wondering if anyone, Jessica's iPad, if you could ping me your last name, Engine One, Ray's iPhone, Alicia, and Rick, that would be great. And if I miss your certificate due to this, just shoot me an email and I'll send it right over to you guys.
Yeah, thanks for that. We certainly need your names for the certificates. And like I said, I'm going to work with the office to make sure that everybody is getting the proper state credits for any rounds that you do attend. See, people are signing off. I'm going to stop the recording.